Good evening, all. I'm Dr. Sumathi, Senior Cataract and Refractive Surgeon in Dr. Agarwal Eye Hospital, Chennai, Porur branch. And I thank the Education Committee for giving me the opportunity to moderate the webinar. And we are going to cover a very interesting topic, which is on corneal neurotization. With me, we have our panelist, who is none other than world-renowned Soosan Jacob ma'am. She is the Director and Chief of the Agarwal's Refractive and Cornea Foundation, Chennai, and she is a noted speaker widely respected for her innovative techniques and management of complex surgical scenarios. She is one among the 5 of the most influential female ophthalmologists in ophthalmology, and she is also listed as one of the top 100 most influential women in ophthalmologist. And she is included in KOL Influencers list of 50 notable global figures in ophthalmology. And she is also included in Stanford's 2021 list of top 2 percentile scientists from around the world. She has innumerable awards and publications for both national and international forum. If I start enumerating this, this webinar will not be enough for us. So we have to have another webinar for it. Welcome, ma'am.
Thank you. Thanks a lot, Sumathi.
And we have Dr. Preethi, ma'am, who is going to cover the topic on corneal neurotization. She's globally renowned orbit and oculoplasty, facial aesthetic, and ophthalmic plastic surgeon. She is the head of oculoplastics and aesthetic service at Dr. Agawals Eye Hospital, Chennai. She has 21 years of experience with who has performed more than 5,000 surgeries, and her special interest is on facial aesthetics, especially orbital surgeries in orbital trauma, virtual planning, and navigation guided surgeries. She is alumnus of SET GS Medical College and Hospital Mumbai, RIOGH Chennai, and Shankar Nethralaya. She is a global examiner for FRCS exams and Asia Pacific faculty, and she is a world woman ambassador for AOCMF, which is a trauma organization based in Davos. She has presented and won awards in national and international conferences. Welcome, ma'am. You can take over from here, ma'am. Thank you, ma'am.
Thank you very much for that wonderful introduction, Dr. Sumathi. It's a real honor and privilege to spend this evening with all of you. Actually, 2 or 3 weeks back, when I was doing a PubMed search on this topic, I came across 158 articles, but most of them, that is 115 articles, were from the last 3 or 4 years. And therefore, I thought this is the most hottest topic here, and I should discuss this instead of some hardcore oculoplastics. It's lovely to share this platform with our corneal colleagues, especially Soosan, who is my PG colleague and college mate. And it's lovely to see her becoming the stalwart in cornea. So coming to some basics, just to brush up, that corneal nerves are needed for ocular surface hemostasis. It is a protective blink reflex. The corneal nerves are needed for that. And corneal wound healing, it also helps in tear production, normal limbal stem cell function, and it maintains the integrity of corneal epithelium. And therefore, when we have corneal anesthesia, you have problems like persistent epithelial corneal defects, recurrent corneal erosions, dry eyes, subsequently leading to corneal opacity, neovascularization, failure of corneal grafts, and visual impairment. So there is a very nice relationship between neovascularization and corneal nerves. I have seen that in our patients. As the reinnervation occurs, the neo vessels automatically, spontaneously disappear. So that is a very interesting finding that we found in our series. So corneal neurotization is a method to achieve reinnervation in an insensate cornea by using healthy donor nerves. Now, whenever we choose a donor nerve, you want the nerve to have good amount of axons, and the nerve should be in proximity to the cornea. Therefore, we use most commonly supraorbital or supratrochlear nerve or infraorbital nerve. These are the common donor nerves. Now, this procedure actually was started in 2009, so it's not a new procedure. It was originally reported by Turgis, who had used a bicoronal incision because in earlier days, it was thought that you can't get the adequate length of the supraorbital nerve unless you open from the coronal incision. So that was a drawback of this procedure in those days. And therefore, because if you make a larger incision, the donor site loss of sensation will be very high. So he had used a bicornal incision and used the contralateral supraorbital nerve and transferred it to the ipsilateral side. So that was a problem because it was a huge surgery. It caused a big hematoma, a huge area of loss of sensation, and therefore it became unpopular. Now the recent methods are more minimally invasive. The downtime is very less. The patient recovery is much, much faster. In one of our patients, we found that reinnervation started as early as 6 weeks. So it can, and it has a very, very promising result. So there are two types of methods, that is direct and indirect. Direct is you're using directly the supratrochlear or supraorbital nerve, turning it into the fornix, and then splitting it into fascicle and placing these fascicles around the limbus. So you're not using any other interpositional nerve graft. Whereas in indirect method, you're interpositioning the donor nerve with a additional nerve that is either a sural nerve or a greater auricular nerve. Now, why this is done? Why do you need to interpose another nerve? That is because many a times the ipsilateral supratrochlear supraorbital nerve also will have loss of sensation. Like in patients with CP angle tumors, the seventh nerve as well as that ipsilateral fifth nerve gets affected. So you need to bring the sensation from the opposite side supraorbital supratrochlear. You won't have an adequate length of that nerve available for you to transfer it from the other side to this side. And therefore, to get that adequate length, you coapt this sural nerve to that side supraorbital nerve. So that is the basic logic between indirect neurotization. So this is how it looks like. Now, suppose your right side cornea is insensate. You're going to use the opposite side supraorbital nerve. Now, this length of nerve will not be adequate because we are dissecting either from the lid crease approach or subbrow approach or a suprabrow approach. So you can imagine only this much length will be available. Now, for you to use that nerve, you can anastomose it with another additional nerve, that is a sural nerve. So in all our cases, we have used sural nerve. Many times, many surgeons use greater auricular nerve also. We split it into fascicles and bring it into the fornix through a blepharotomy incision. And then these fascicles can be placed around the limbus through various techniques. Either you can do a peritomy and place the ends at the limbus, or you can make several sclerocorneal tunnels and place the nerve endings inside the tunnels and then suture the conjunctiva over it. This is how it looks like. If it is the opposite side supraorbital nerve, we can anastomose the sural nerve to it either end to side or end to end. Now, since it was our new series, I preferred an end-to-end because then you are 100% sure that the nerves are going to go in that direction. But end-to-side coaptation ensures that the loss of donor side sensation will be a little lesser. So there have been some studies from Canada which have shown that if you do an end-to-side coaptation, then the loss of sensation in the donor area is minimized. But we wanted to have our series prove that this procedure works before we try the end-to-side anastomosis. Now, this is how the infraorbital nerve can be used. Now, actually, the infraorbital nerve thickness is much more than supraorbital. So you can get larger amount of fascicles when you transfer this nerve. And also you can do a good coaptation between the sural nerve and the infraorbital nerve because the diameters are almost similar. Whereas when you use the supratrochlear nerve, the diameter of the supratrochlear is smaller than the sural nerve, and that we need to adjust when we are anastomosing. But what happens in infraorbital nerve when you use that as a donor? A large area of the cheek, the upper lip, the teeth, as well as the side of the nose lose sensation, which the patients are not very happy with. Therefore, in all our series, we have not used infraorbital nerve. We use only the supratrochlear or the supraorbital nerve. Now, there was a series which was published by Fogagnolo et al. In 2020, and he compared direct versus indirect nerve grafts, and they found equal results at the end of 1 year. So whenever you do an indirect transfer, obviously it's going to take longer time to reinnervate because the impulses have to travel longer. Whereas compared to that, a direct one will have faster recovery of sensation. But at the end of 1 year, they found that the results are almost the same. Now, what are the indications? That's what Dr. Sumathi was asking me in the beginning of this webinar. Now, you can choose any case which has lost its sensation and is having neurotropic keratopathy. So there can be local causes or systemic causes. Local causes can be post-herpetic, which is the most common. So now these patients don't have complete loss of sensation, but they have reduced sensation. And the loss of sensation can be also sectoral. So when you check these patients, make sure that you check in all the quadrants. And also, if there is reduction in sensation in these patients, also neurotization helps, because once the sensation improves, then your results of PK or DALC, which you are planning subsequently, also may improve. Then other causes can be iatrogenic. People on long-standing ocular topicals like anti-glaucoma medications or topicals with preservatives can cause a loss of sensation. Ocular procedures sometimes can cause ocular anesthesia. Chemical burns, corneal injury or injury to ciliary nerves, and diabetic patients. So many a times, if you see diabetic patients, they have recurrent corneal erosions, SPKs, and these patients, you please check the corneal sensation. And if the sensation is reduced, neurotization will help. Also, some pathology along the trigeminal nerve pathway. So this is what I was saying. Very commonly, we as oculoplastic surgeons see these kind of patients because facial nerve palsy patients get referred to us. And most of the time, they've had a CP angle tumor excision, wherein the fifth nerve also gets affected along with the seventh nerve. And therefore, when you check the corneal sensation, and if it's absent, even prophylactically, you can do a neurotization in these patients. Also, the many cases that we are seeing today, and today I operated on one patient, was Gasserian ganglion ablation was done for trigeminal neuralgia. So very often now I'm seeing the third patient in our series who had a trigeminal neuralgia, and the neurosurgeon had done an ablation of the fifth nerve. And then the patient landed up with corneal opacity because of loss of sensation. Also, post-trauma, if you see skull-base fractures can affect the trigeminal nerve, or any kind of lesion where there along the pathway of the trigeminal nerve. That it can be trauma, it can be malignancy or stroke, and sometimes it can also be congenital familial dysautonomia. We are yet to do a congenital case in our series. So these are the kind of patients that you will see. That this is a patient who is a facial palsy patient. You can see a tarsorrhaphy is being done by somebody else. And look at this cornea. Now, even if you want to do a visual rehabilitation of these patients, you need to create that healthy bed with good corneal nerves. And hence, neurotization should be advised before any corneal procedure in these patients. Another patient, non-healing herpetic corneal ulcer. You can see how the surface breaks down. These are the ideal cases for neurotization. So this was the common causes of neurotropic keratopathy, which is mentioned in the textbooks. And these are all indications for neurotization. Now, in our series, we had excluded patients with active infection because there have been no studies which have shown that when there is very active infection, whether these nerves will survive or not. So we didn't want to take a chance in our series, and therefore we have not done any patient with active infection. We had one patient with fungal corneal ulcer with a desmetocele. However, her active infection was controlled. She had corneal melting, and that's the stage wherein we took up the patient. Also, there's an absence. If there is absence of healthy sensory donor nerves, of course, we can't do this procedure. Or if there is an ongoing external beam radiation, we at least wait for 6 months after the radiation before we do this procedure. Relative contraindications can be extensive conjunctival scarring and patients with poor general health. Now, pre-operatively, you need to check the corneal sensation. There are various ways in which you can do it, either with a wisp of cotton. That is what we did in our initial series till we got the aesthesiometer. Now we have the aesthesiometer. Now, in this instrument, we check the sensation with a nylon filament. And the length of the filament tells you how sensitive the cornea is. So the longest length is 60 millimeter, which is the 6 mark on that aesthesiometer. And that when the filament is very long, the cornea has to be very sensitive for it to perceive that sensation. And then as you reduce the filament length, the filament gets stiffer, and it is easier for them to perceive the sensation. So here you can see that this patient has completely lost her sensation. Even the shortest filament she is not able to perceive. And then the other way is confocal microscopy. Now for our last few patients, we have done confocal microscopy and shown that there were no corneal nerves. So this is how a confocal microscopy picture looks like. And here you can see that nerve plexus layer is totally absent. So you get these scan images at various depths of the cornea. Usually I tell them to check in 4 quadrants as well as in the central cornea. And you can see that there are no corneal nerve fibers in this particular patient. This is our patient from CMH. So there have been studies which have proven that confocal microscopy is a useful tool for us to diagnose preoperatively absence of corneal nerves and also to prove reinnervation postoperatively. Whenever we assess a patient, we do a complete ocular examination, slit lamp examination, including fluorescein staining and Schirmer's test. Eyelid examination, if there is any malposition, trichiasis, lag of thalamus, we like to correct that before we take up the patient. For lag of thalamus, if there is a facial nerve palsy along with the fifth nerve palsy, we sometimes combine the two procedures. We have done that for 2 patients. Examination of other cranial nerves, of course, is important. And donor side sensation mapping is the most important thing. So that is how I decide whether I want to do a direct or an indirect. So ipsilateral side, if you have a good sensation along the supraorbital supratrochlear, I would prefer to do the ipsilateral side. A slight modification that I have done from the studies, from the other studies which have been published, is that everybody, all the other studies have shown use of upper lid crease incision or a sub-brow incision. But I have used mostly a supra-brow incision. In that way, you can get a longer length of the nerve. The problem, what we see is that the nerve is deeper proximally, but it gets much more superficial as you go higher, and you need at least a 4 centimeter length. And therefore, so when you are dissecting, you need to dissect in all the planes, deeper, middle, and then superficial. Because if you go very deep and then start following the nerve, you will lose the terminal nerve fibers. And of course, we have done now slit lamp photography and esthesometer videos for all the patients. Pre-procedure, we'd like to stop all unnecessary topicals, so we don't put the patient on any antibiotics, and also preservative-free topicals. Some of the patients now in the recent past, we have also done punctal occlusion to improve the ocular surface and address any comorbid eyelid changes, eyelid conditions. Now coming to the graft, I have taken only sural nerve for all the patients in whom we have used contralateral nerve donor. Now, sural nerve anatomy, it is a nerve which is a good sensory nerve present on the back of the calf. So we mark the area in between the greater trochanter and the lateral malleolus and follow the sural nerve at least now 10 to 15 centimeter length of the sural nerve is required. And that is the length that we use for dissection. We have to be careful about the short saphenous venous plexus, which is along the nerve. And many a times a common sheet encloses both the nerve as well as the vein. So this is how the markings are done. And here I'm harvesting a sural nerve graft. So the dissection has to be very superficial initially. And as we dissect deeper, we should distinguish between the saphenous as well as the sural nerve. There is a lot of anatomical variations because the medial and the lateral cutaneous sural nerve join together to form one common sural nerve branch. Sural nerve, and there is a lot of variation in this branching pattern, and therefore we should find a good trunk of nerve with good fascicle density for us to use for a transfer. So here you can see that the short saphenous is what is seen inferiorly, and what I'm holding now is the nerve. So what I'm using is the nerve holding forceps, and we separate the nerve completely from the surrounding fascia. We need at least now here I have used only 7. So this depends on the measurements that we take on the patient preoperatively. Here I think 8 centimeter was adequate, but today's patient which I have done was 12 centimeter long nerve I have used. And then this nerve, sorry. So then the sural nerve is passed from the contralateral side to the ipsilateral side. And then this I am passing the sural nerve to the superior fornix through a blepharotomy incision. So now I am dissecting the supraorbital nerve on the contralateral side. So that is the supraorbital nerve. I am just separating the facial tissue from the nerve here, because if you have a very bulky nerve, it will be seen post-operatively and the patient will not be happy with the cosmesis. So I hope you follow this because the right side is the donor nerve. And now I am anastomosing the sural nerve to the supraorbital. So you can see the diameter disparity here. We must make sure that the perineurium to the perineurium anastomosis is done perfectly. Otherwise, if there is an exposure of the nerve fascicles, it can form a neuroma, which can be very painful. So here, this was the coaptation which was done. And now the end of the nerve, which is on the cornea, we split it into fascicles so that we get at least 4 or 5 fascicles to be placed around the limbus. So this was our initial videos in which I used to do a 360-degree peritomy and then place the fascicles just with the end facing the cornea and then close the conjunctiva. In this patient also, we had very good reinnervation, but I find that the patient comfort is little less when you dissect the limbus. I mean, when you do a peritomy. So instead of that, now we do the conjunctival incisions about 4 millimeter away from the limbus. So these are the fascicles which then now will be placed along the limbus. Now, when we take these bites, we have to be careful to take only the perineurium and not damage the nerve bundle. So this was a 21-year-old girl with a facial palsy and so this is how, and at the end of the procedure, we do a tarsorrhaphy. Now, this is the modification in which we make the incisions a little away from the limbus and then tunnel these nerves from one incision to the other. And today's case, I have made a sclerocorneal tunnel so that the nerve lies at the stromal level itself. And you can see the nerve endings on the slit line. So our study had a total of 13 patients now, which we have the largest series. Even about 2 years back, L.V. Prasad Institute had published a series of 7 patients. Here we have 13, out of which 6 were done in Agarwal Hospital, that is in CME. Out of which 7 were males and 6 were females. Age range was from 21 to 65 years. Etiology was 3 patients were diabetics, post-herpes trauma was in 1 and post-fungal ulcer in 1. 4 patients had CP angle tumor excision and 2 patients had Gasserian ganglion ablation. 7 patients were ipsilateral and 6 were contralateral, and our follow-up is from 1 month to 20 months. And there was complete improvement of sensation to 60 millimeter in 8 patients, and sensation improvement starts from 6 to 8 weeks and is complete by 6 weeks to 10 months. Ocular surface healing was seen in all patients. The rest of the patients did not have improved corneal sensation because we don't have that much of a follow-up right now. So a few of our patients are very recent. But the ocular surface stability happens quite early by 6 to 8 weeks. Corneal procedure is known to be successful in few of the studies which have been published. We have not done corneal procedure in any of our cases, but our post-op results have been seen by Soosan and Dr. Preethi also. We have seen that the sensation has recovered completely in those patients. So this was a study which was published by the Canada group on 19 eyes, and they had done a cornea procedure in 4 patients. PK and DALK. I think 1 patient was PK, 2 were DALK, and I think 2 were PK and 2 were DALK in this series. And they showed that the corneal procedure was successful. And they also showed corneal nerves in the histopathology of the excised corneal button. So that is what we are also planning in our series. As Dr. Soosan takes up these patients for cornea, we will do a histopathology and prove that the nerves have grown inside the cornea. So this was one of our patients where we have done ipsilateral. So ipsilateral means you dissect on the same side, the supraorbital. We are able to get the adequate length even with this small an incision. That is because it is a suprabrow incision. And this was a patient who had a 2-year-old persistent epithelial defect with corneal melting. It was a Mackie stage 3. And this was the result at 4 months post-op. You can see how stable the cornea is now. And you can see the nerves here beautifully. These nerves become translucent and become flatter as time goes by. And this was a recent picture, which is 1.5 years follow-up. And the cornea is pretty stable now. And you can see the nerve has also become flatter and paler with time. And in esthesometer also, you can see the same patient I had shown you before. She had insensate cornea, and now you can see that there is sensation. Even up to 6, she has sensation. So there's a thin filament and she still feels it. So we normally give at least 4 stimuli, and if the patient responds to 2 stimuli, it is considered to be positive. So this is how the patient looked like at 1.5 years follow-up. The eye is quite white. Even her dry eye is improved and she's symptomatically so much better. Another patient with desmetocele with fungal corneal ulcer, as I said, the active infection is controlled. We have done this again, ipsilateral transplant, and here I also used a blue BCL for the desmetocele, and this was the modification that we did in this patient. This was another patient, facial palsy with a fifth nerve affected. This is after neurotization. You can see the surface is so much better. She is also symptomatically better. And the suprabrow incision is not very obvious in most of our patients. This was another patient. This was the cornea at 6 months follow-up. You can see the beautiful corneal nerves, and the cornea is also very much stable. And this patient, we did a confocal yesterday, and it has shown nerve fibers. Can you see this? These linear hyperreflective areas are the nerve fibers. Nerves are seen. So this was just a yesterday's report, and we have seen real promising results. There has been a study by Park et al. In 2020, which included all the published articles and meeting abstracts between December 2008 and February 2019. They identified 54 eyes that underwent this procedure, and all of them had a significant return of corneal sensation in all their cases. The recovery they have shown is faster in children, and there is no cutoff in terms of time since pathology. Like we have patients who have had 2-year-old, 3-year-old pathology. They still, this procedure still works well for those patients. And another study by Elbaz et al. Have shown both direct as well as indirect nerve transfers have equally good success rate. But in India, there have been only 2 studies published so far, out of which, and both the studies showed only indirect way of corneal neurotization. This was a study by L.V. Prasad, which I was mentioning in 2022, which showed only 7 patients, and they have not shown actually the confocal results of their patients. And there was another study which was in a non-peer-reviewed journal, but this was also using the indirect method. Now, the possible complications that you can have is subconjunctival neuroma in some patients, which has to be excised, or there can be a Delin if the nerve is too bulky. So therefore, we try to reduce and remove all the fibrous attachments. One of the patients had a cosmetic concern saying that those nerves are seen. So what the published reports have shown is that after 1 or 2 years, these nerves become relatively flatter and translucent and are not very much visible. Of course, donor site loss of sensation is an issue. In the leg also, but they usually have a very small area of loss of sensation because the surrounding nerves take over the innervation. Similarly, forehead loss of sensation is not much of an issue. We have not used the infraorbital nerve for this reason. Donor site infection and hematoma can be seen. We had one patient with this problem where we had to remove the hematoma. Thank you very much for this wonderful opportunity. So this this particular procedure, that is neurotization procedure, has extremely promising result of cure in a very difficult to treat neuropathy, neurotropic keratopathy cases. And we can also provide a healthy bed for optical rehabilitation through a penetrating keratoplasty or a DAL. Thank you.
Thank you, ma'am. That was a wonderful coverage of the entire topic. And the videos were also like very interesting to see. Like it's, I want to come and watch you doing it, ma'am. Ma'am, there are a few questions like which was there in the chat box. Before that, Soosan, ma'am, like your inputs, ma'am, regarding this. It would be very nice to hear from you also, ma'am.
Yeah, I think this is basically a really nice kind of a newer surgical procedure which has come up, which has really helped us as corneal surgeons, because neuropathy has always been a kind of a bugbear when you have a neuropathic surface, which could be because of so many reasons, as Preeti enumerated. The final, and keratoplasty, when you do keratoplasty, also remember that you're also inducing some amount of sensory neuropathy, because you're having a full thickness incision, and that itself cuts off the nerves. Okay, so you already have a cornea that is hypo, what do you say, hyperesthesia. It is not actually having full sensory innervation, and on top of that, if you also do not have sensory innervation in the peripheral host rim, then it becomes a very difficult situation for healing to happen, and that's when you can have stromal epithelial defects, stromal melts, vascularization starts, and vascularization becomes a risk factor for rejection, and then you have a poor corneal surface, and infections can happen, and all these things, they just keep going on, and finally you have stromal opacities and over the visual axis, and then you just would have lost your entire purpose of having done a graft. So this is something that is great, which is really a good advance. Earlier we would have to do tarsorrhaphies, amniotic membrane grafts, and all these things, but I think this will definitely, maybe you might still need a AMG in the initial post-op period, just to kind of hasten things along. But this neurotization, which brings back sensations, is definitely of help. And I've seen Preethi's results, because we co-manage some patients, and it's really, really good. The sensation does come back, and the patients seem much better, comfort-wise. Their tear surface, their tear film is better, their blink reflex is better, because now they can actually feel the sensations. So the entire ocular surface improves after this, and that gives us a much healthier bed to transplant on. So yeah, that's something that really helps us in our management.
Yes, ma'am. Thank you, ma'am. Can we go into the chat box questions, ma'am? There are certain questions like Dr. Preeti is asking how much time the entire procedure takes, ma'am. To Preeti, Udhay, ma'am.
Yeah, so it all depends now as we keep doing, because we find so much of anatomical variations in the nerve. So I think the nerve dissection takes the longest, especially supraorbital, supratrochlear. Sometimes we have 3 trunks. We have to find out which is the thickest trunk, and then it's at different levels of dissection. So, but we have finished procedure in 1.5, 2 hours also in one patient, but sometimes it takes much longer. Like today's case took much longer because the supraorbital nerve had a lot of variation. Sural nerve is relatively easy to harvest. In fact, most of the series that I see, they call in a plastic surgeon. We had only the first patient being operated by a plastic surgeon. Remaining all we could do easily. I think sural nerve harvesting is not a big deal. The problem is the supraorbital, supratrochlear. Also, the corneal aspect, I mean, you guys can give me input on which would be the best, but I think now the tunnels, the corneal tunnels that we make are the best and easiest, because I feel you're placing the nerve at the stromal level. So probably it may be a little faster. So we should compare the result between this versus when you keep it at the limbus, whether it takes longer time that way.
I think I'll agree with that. They'll probably, you can kind of also distribute the tunnels, even depth-wise, so that some of them are more superficial, so that you also get a subbasal plexus forming, and you also have a more deeper depth, so that you have a stromal plexus forming. And I think it will not just be that; it'll also add a lot to the cosmetic, outcome for the patient. So if you're tunneling right from the sclera, you won't have these nerves visible, and that itself, I think, will make the patient happier. It'll also make the ocular surface smoother, because you don't have any bumps on the surface of the globe anymore. So the entire tear film will become smoother if you do
These
as a
tunnels will be only in the area where the nerve endings ends, but then you will have to tunnel it from the 12 o'clock position to the 6, no? So subconjunctival conduit will be there, but they won't be around the limbus. It will be little away because the tunnel will be a little away.
Exactly, but you're having a scleral component also to the tunnel, right?
Yes, but that is only at the area where you're leaving the nerve ending. It will be in 3, 6, 9, 12 positions. 4 or 5 tunnels you need.
So my question is, can you kind of tunnel through the sclera right from where you get it? Have a long scleral tunnel, and just, maybe you can use a MST forceps or something and just grab it, and then, also put it into the cornea. That will give you a flatter surface as well as cosmetically better. Maybe it may also keep the nerves healthier. I don't know, because it's not, repeatedly having the lid action on it and things like that. So that maybe that might be a variation that could possibly be.
Yeah, and maybe next case we can have a good discussion on this and try it. I don't know how easy it will be to go 360 degrees, but we can try.
Hmm.
Ma'am, I have a doubt. Most of our corneal nerve innervation nerves are all have lost their myelination sheath, and when they are entering into the stroma. How about these nerves, ma'am? Like, do they retain their myelin sheath, or like, how do we explain that, ma'am?
So this nobody has studied. I think only the one study which showed histopathology specimens, no, the 4 cases that they did. In that, probably we can prove that. So I think Dr. Susan is going to operate on 2 of my cases. When she does that, we'll send the corneal button, and then we'll try to find out what kind of nerve was seen, and whether the myelin sheath was there. All that we'll have more clarity then. And they've also seen that once you do a transplant, then in your transplanted cornea, also these nerves then grow from the periphery to the graft. So that is shown by one series in Canada.
Okay, okay, ma'am. There's one more question about learning curve for the procedure, ma'am.
That's what I was saying, no, like learning curve is very long, of course, and we are still innovating because there are not too many studies. Even from all over India, I said only 2 studies are there, and one is non-peer reviewed journal. So there was only one study by LBP. They also have not shown their confocal microscopy results. Only 7 cases they have done, and that is all indirect only. So I think we will evolve as we are going. So of course, the learning curve is long.
So indirect is the preferred technique, right, Preeti?
No, it depends on if I have ipsilateral sensation present, I would prefer ipsilateral any day. Why should you rely on the sensation going to the sural nerve and sural nerve transferring?
You mean ipsilateral sensation in the forehead area? If it is intact, then you would prefer that.
Yeah, I would rotate that nerve itself. That's what I showed, no? 2 or 3.
And you get the length when you rotate that?
I'm now able to get the length. Initially, we could not go up to 6 o'clock limbus.
Okay.
But now we are able to get the length. That's why I said, like, you have to dissect in various planes. Otherwise, the short branches just get cut off very easily.
Okay.
So we start off with superficial and then go. So that's why we take longer time now. But I think as we are more familiar with that anatomy and variations, will be faster.
Okay. Makes sense.
Ma'am, any chances of these nerves being exposed? Like, it's all only under conjunctival coverage. Like, any chances like they can actually lose their place where they have been there, and they get exposed?
Yes, so there have been some studies where they have just left the nerve endings in the tunnel. But what we are doing is we are suturing also, and I'm also suturing the conjunctiva and not using glue. One case I had used a glue, and one of the incisions, the conjunctiva retracted little bit, and I was afraid that the cornea will, the nerve ending will get dried. So I resutured that one bite I took again. But
Okay.
I'm not sure whether we can just leave glue. Initial cases I don't want to take a chance, so everywhere I'm putting sutures and making sure that they move.
Okay, ma'am, you take the sutures along the perineum. Is there any role for fibrin glue to adhere the nerve fibers under the bed, ma'am?
Yes, there are people who have used fibrin glue, but I think the glue will interfere with the ingrowth of nerve fibers.
Okay.
So I don't want any barrier there. So I think suturing will be better. And even the other studies have shown suturing only.
That's probably.
Ma'am, there's one more question. Like, do you take the when you're taking a harvesting the nerve, maybe a sural nerve, do you take it with the vascular leash of it? Because the moment you cut it, like, how are they? How are they viable, ma'am? Like, from the main branch.
They have the pile plexus and all that, right? They don't.
Okay.
The branch is not needed, and they will get the vascularity from the bed then, where we are transplanting.
Okay, wherever the place which they have been placed, they get the vasculature from the in and around the surrounding
area. The ulnar nerve has its vasculature, right? The sural has its vasculature that will supply the sural nerve.
Okay. Any chances of rejection when we are, especially when we are taking another nerve and direct side to side or end to end transplant, ma'am?
This is an autograft, and therefore we don't see rejections because I have discussed a lot with my plastic surgeon friends. They do nerve grafts regularly for other reasons. And they find that neuroma is the biggest problem. And in one of the series, they have reported a subconjunctival neuroma also in neurotization. But rejections we never see. It may not work, that's all. I mean, maybe the impulses may not come up to the cornea, but it doesn't get rejected as in necrosis, things like that.
Ma'am, there are a few more questions. Like one is like to explain about corneal esthesiometry again, and the process of reinnervation back into the cornea.
So esthesiometer is very simple. It is got a filament. I think I showed that.
Yes, ma'am, you showed.
So it's got a filament. So each marking is 10 mm. So when you put it at mark 1, the filament is thickest and short. So if something is short, stiff and thick, it's easy to perceive. So you just touch the cornea in the center. We give 4 stimuli, 4 times we touch. And then patient has to, I mean, you see the blinking of the other eye if needed. And once he perceives, then you go to the other 4 quadrants and we note the values as central, 12 o'clock, 6 o'clock, 3 and 9 o'clock positions. So that is how we are checking. So here, since it's a post-op patient, I am not, this was like a second or third time that we were doing. I'm just checking a recovery and you can see, and this patient is little uncooperative, so all the quadrants we didn't check, but you can see beautifully that the central cornea is there. So the last one which I did was a long length. That means she has very sensitive cornea now. It is responding beautifully. This is a shorter one. So you just have to slide this. So shorter one is very easy to feel. So, and you note the result as 0 to 60. Any other doubt in this esthesiometer? I mean, I thought it is.
No, ma'am. Actually, they just wanted to know, see the video, I think, again. So you have already explained. Maybe they wanted to see the Cochet bonnet esthesiometer again.
That is the Cochet bonnet.
Yes, ma'am.
What was the other question?
Ma'am, the process of reinnervation back into the cornea, ma'am.
The nerves just grow from the limbus to the midstroma, and then they come subepithelial and epithelial. So see, what the whole logic is that they found that peripheral nervous system nerves regenerate faster than the central nervous system. That is basic physiology that we learned. Therefore, we prefer one of the peripheral sensory nerves to reinnervate. And when you're doing ipsilateral, the same side supratrochlear, you're just bringing it into the fornix, splitting it into fascicles and putting it around the limbus. The nerve endings start growing into the stroma and then they go upwards into the subepithelium and then the epithelium. So now our next thing, since we had access to confocal only since few months, we are going to do this study and see at what level we can see the corneal nerves in which quadrants and all that. But confocal is not very easy to do. It is an immersion method in vivo confocal microscopy, and therefore patients don't cooperate that much to check in all the quadrants. So we tell them to check in the quadrant in which we have placed the nerve endings for us to actually study that quadrant.
Ma'am, there's one more question. As an indication in SJS patient, Stevens-Johnson syndrome, they've asked.
If there is not too much of conjunctival scarring, so if you are able to place the corneal nerves comfortably, there is no contraindication. There should not be any active infection, and there should be a loss of sensation in the cornea, which is causing these corneal breakdowns. If you can prove that, we can do a neurotization.
Ma'am, Soosan, ma'am.
Yeah, also please remember that SJS syndrome is not pure neurotrophic keratopathy alone. There's a big component of limbal stem cell deficiency, which is also there, severe dry eye syndrome. So those components will not be taken care of by the neuropathy. Yes, there might be a neurotrophic keratopathy component also, but just doing this alone and without treating the rest of it will not help. So it's all going to be a treatment like complementing each other. You would have to do a limbal stem cell transplant. You would have to fix the eyelids first, because they'll have cicatrizing and trichiasis and entropion and stuff like that. You might have to form the fornices because that will be another problem for these patients. And then along with that, maybe you can do a neurotrophic keratopathy. I'm not sure if it's already been tried anywhere. And along with that, you will have to do limbal stem cell transplantation also, because that's a major component of SJ syndrome.
Ma'am,
This was another thing, Dr. Soosan, which I was thinking is whether we can combine these, or you need to do first the eyelid and everything, wait for it to heal, and then do the reinnervation, or we can do everything together and do a toxic.
I think you should be able to do the eyelid and the neurotrophic, the reinnervation together, because the reinnervation is not going to be dependent on your tear film. I think it's just going to be based on whether you have a non-inflamed eye that you could do with steroids, I guess. And if you and you're going to do a tarsorrhaphy, do you do a tarsorrhaphy also generally after this?
I do for all patients tarsorrhaphy.
So if you're doing a tarsorrhaphy, you've nicely formed your fornices, then I'm pretty sure, because already you're doing some amount of conjunctival dissection. Along with that, you could just finish off your neurotization only. Only thing is it's going to be a huge long surgery. So you'll need to have 4 pairs of hands, consecutively, not even simultaneously.
No, we can do consecutively, one after the other.
Yeah. So yeah, I'm pretty sure you should be able to do it. The only thing is you'll have to do a corneal procedure at a later sitting. And I think one thing I want to know is, what is the medical management that you normally put them on post-operatively?
So most of these people have corneal issues like persistent epical defect or SPKs, and also I give plain Vigamox preservative-free antibiotic for 2 weeks, and I just give lubricants. Don't start on steroid till the surface becomes a little better. Usually they become better by 2 weeks or 3 weeks, wherein I start the steroid, and that too only 3 or 4 times a day. I see one of the patients at 6 weeks itself, the surface had completely stabilized. So surface stability we see very quickly, but the sensation recovery takes at least 2 months or 3 months. One of the patients took 10 months. For the first patient took almost 10 months.
Okay.
Ma'am, Soosan, ma'am, this question is to you, ma'am. Suppose we have done a corneal neurotization, Dr. Preethi ma'am has done a corneal, but patient is waiting for a procedure. So how long and what will be the parameters you would consider to decide, like, okay, now I can operate, or shall I wait? Like, what are the things like in your mind, from your perspective, ma'am?
So if I am doing a keratoplasty on these patients, I would want to kind of assess what is the diameter of the graft I'm going to take. So if it's going to be, let's say, 7.5 millimeter graft or an 8 millimeter graft, I'd want to have sensations at least up to 7.5 or maybe 7 mm. Because the central part further beyond that does not matter, because anyway, I'm going to be removing that cornea and putting in a new cornea. Even if I'm doing a DAL, it would be the same, because I'm going to be removing all the way up to the predesmens layer. So there the sensation is irrelevant. So as long as I get the donor area, I mean the host area reinnervation, that should be fine. I wouldn't want to wait till it goes all the way to the center, and that's a waste of time, and it's not going to serve any purpose because you're going to cut it out anyway.
Okay. Ma'am, any number of quadrants, like 1 quadrant, or like maybe around it started innervating the peripheral cornea, or like you would prefer like 1 quadrant, or like
Ideal situation is always, of course, full 4-quadrant innervation.
Yes,
but if that is not the case, at least I would prefer the exposed quadrant, which are the nasal and the temporal. It's because the upper and lower, and especially if you want an order, nasal temporal followed by inferior 6 o'clock, and then the superior, because superior is covered by the lid to a much larger extent. There you get breakdown much less. So it's mostly the exposed area that's going to be much more prone to breakdown. So there it would be better if we get it. But then we can always do other things. We could do a tarsorrhaphy after the keratoplasty, just till the surface stabilizes more. So those things can definitely be done and considered for such patients.
Okay. Yeah.
I want to know, Preeti, if the patient is diabetic and you expect some, neuropathy in the nerves also, peripheral nerve, sural nerve and all, is there anything different that you do? Or
So I was just hoping that, we have some trophic agents which we could add with this. So earlier, like there have been discussions on nerve growth factors, but they are so expensive. They're like 60 lakhs here. Not even available in India. And they have only a short-term benefit. And that too, they have benefit of improving the ocular surface, but not a re-innervation. Even if you put a nerve growth factor, they have not shown that the nerves have improved. So that was one aspect, whether we can use anti-VEGF or some kind of growth factors which will hasten this process. Maybe we have to look into that.
So I think one thing that maybe we could try is platelet-rich plasma.
Okay,
Because
PRP.
that could help, it will help in multiple ways actually. It will also stabilize the surface to a large extent. So that's another very good thing.
Okay.
Um,
We're using PRP for the face. So I think
huh,
same way we can use, you know.
same, yeah, we can just give it as drops basically, to put post-operatively.
There was another thing that I was thinking is we are using PRF now, platelet-rich fibrin membrane for our
Huh.
scars. So we just
So
place
put it
it
as
on
the surface on
scars,
top.
yeah, and do a dermabrasion. But it is good even in very bad orbital fractures. I'm using the PRF membrane to form kind of a barrier. It's like a biological barrier in between the inferior rectus and the implant that we use on the
Oh,
floor. So I
okay.
was thinking whether we can use these kind of membranes on the surface, whether
Of
any
of the
reports of PRF membrane.
Not really tried them, no, never tried them actually, but it would be nice to see, how that works. Actually, I would be quite interested. Can you pass sutures through it?
Yeah, but it's a very soft membrane. It's basically a
It'll be like
coagulum,
glue. Yeah, it's a coagulum. It
like
will
a
be like glue.
coagulum, but
I
it is
guess we
quite
could try
stiff.
it and then put a bandage contact lens over it so that it stays there.
Yes, exactly. That's what I was thinking.
Hmm.
It has got a lot of growth factors,
Hmm.
and the PRF is known to be better than PRP, actually.
Yeah,
It,
because
it
more
would have,
concentrated.
and it will improve the comfort also of the patient, I think.
Hmm. So just for those who may not be aware, some of the other things that you can use for epithelial breakdowns are also topical insulin. That's also being tried now a lot. Topical insulin drops. That'll again improve your epithelial surface for non-healing epithelial defects and all. And PRP, autologous serum, has been done for long, and we use autologous serum very, very frequently, and we find it gives excellent benefit. Platelet-rich plasma is also supposed to be very good, but you need actually. There's a company here which provides PRP kits actually, and you can make PRP from that and give it to the patient to apply post-operatively. We could also try this fibrin membrane, which Preeti just mentioned. So various things are there which can be used. And oxervate is basically the nerve growth factor, the Senegermin, which is
Mm.
available outside and which is exorbitantly expensive,
Yeah.
though.
So this insulin drops, are they available in India? How expensive are they?
Yeah, you can actually reconstitute them from the normal insulin which is used for diabetic patients. So I've tried it also. I've tried it. I was not like thrilled with the outcome because I get a better outcome still with autologous serum. But these can be just add-on things when you are having a really tough patient, which is difficult to get to epithelialize.
That's nice. I think what the studies have mentioned is you need to really try all these other measures before you embark on surgery
And so, yeah.
to stabilize the surface. So I think probably we can go through all that with our patients before we do the surgery.
Yeah, HSV patients would be one great category of patients where we can do, because it's you do get these patients once in a while. They sometimes have stromal scarring,
Mm.
and then you need to do keratoplasty, and they already have challenging situation because of a possibility of recurrence. So along with that, if we can do this, it's probably a useful thing to at least get rid of the neurotrophic keratopathy part of it.
But what I have seen in whatever cases we had is there is not a complete loss of sensation. There's a reduction in sensation.
In
But still it
HSV.
will help, I think. Yeah,
So
this is
would you do it for these patients also?
yes,
You're doing it, right?
yes, we're doing it.
Yeah.
So instead of 60, if you're having just, the sensation is like 10, 20, then it will help.
Correct.
Oh,
Somebody
it-
asked a question, how's the pain level post-procedure?
yes.
No pain because we are doing tarsography. The surface is it's fill it, shut it kind of thing. They don't have any pain. And the scar is also so small now. We are making such small incisions. And I find that this modification of having suprabrow is really nice to get the length. So ipsilateral, I am able to do quite a bit. And so you've seen that one of the ladies which I showed with facial palsy, you can't even see the scar. Such a small scar, they just recover so fast. Next day they have a tarsography and there's a small wound here. They can do all their normal activity.
One more question to you, ma'am. Like, okay, we have done on neurotization procedure. Okay, like how long do you wait? Like, okay, will you repeat it again? Like, if corneal sensation has not come, and if so, like, when, and how you will decide, ma'am?
I don't have an answer to this
No
right now,
procedure to
actually,
repeat.
because I was desperately waiting for the first patient to show some sensation, which came at 10 months. So we don't know how long we will wait, for these, and when do we call it a failure?
Yeah.
So I think that will take some time for us to answer.
So what you have to know is that it does take some time. It's not like do it and next day the sensation returns.
Yeah.
It does take some time for the sensation to return, and you have to patiently wait for that to happen.
I tell the patients in the counseling itself that you're on a 1-year journey with us. It's not going to happen overnight. And at the end of 1 year only, we will think of visual rehabilitation. Basically, they all are concerned about the vision. And they say, oh, you have done so much and nothing has happened. For them, it's the same. So, of course, symptomatically, this recurrent erosions and the surface becomes stable. Symptomatically, that way they are better. But vision-wise, I think they have to wait still.
Ma'am, thank you so much. And I take this opportunity to thank both Soosan ma'am and Preeti ma'am on behalf of Education and Clinical Board to give a wonderful talk. And we had a very nice interactive session, and it was so nice. Actually, all of us learned. In a way, I also learned, and I read a lot. I'll take one of your appointment. Come and see you the surgery too.
Thank you very much.
Thank you, Preeti ma'am. Thank you, Soosan ma'am.
Thank you. Thank you so much.